Thank you very much.
Okay, Antonio, Toesca, thank you so much for your extraordinary presentation. We are very excited about your data and also about your results. The aesthetic results are astonishing. First of all, I'd like to ask Fabrizio Brunelli to make his first considerations, and feel free to talk about the presentation, Fabrizio, and also about the breast reconstruction, please.
Well, first of all, good evening, everybody. Thank you very much, Hélio, João, for inviting me to watch this masterclass of my friend Antonio Toesca. It's really an honor, and it's very exciting to discuss about robotic surgery. I think the future is already happening, and Toesca is the pioneer of it. So, it was very nice, your presentation, Antonio, as usual.
Thank you.
And we are very excited when we watch your videos and your data about robotic nipple sparing. I think it's a way of treating breast cancer and prophylactic surgery that will be more often in our day-by-day clinics. It's still very expensive for us. Because many places we have robots, but we have to fight with urologists, with gastrosurgery. So everybody wants to go to robot, and we feel that breast is still left beside. And you are showing some good data that we can use on breast surgery. One thing that is very interesting, now the data, your data, the data of Benjamin Sarfat, is that you have less complication in robotic surgery and you have better outcomes, especially patient feeling the nipple areola complex and feeling like itself, the breast itself. Can you imagine why is that? Do you think the surgery, the dissection is more, I don't know, how can I say? It's a better dissection that you don't harm the nerves. Is it a point that you think that can explain that?
Well, I don't have a physiological explanation to that. What can I say is that the thickness of the mastectomy flap is very precise, because you can evaluate the distance between the gland and the subcutaneous tissue and the skin and so on very better than in open technique, especially for the inner quadrant, especially for that quadrant that it's difficult to reach during the open surgery with the intramammary fold incision or periareolar incision or upper outer quadrant radial incision and so on. And I have to say that the fact that many patients preserve the feeling, the innervation of the nipple areola complex can be done because the absence of the incision in the breast. Maybe the position of the incision off of the breast in the axilla do not interfere with the radicular, with the web of radicular innervation of the breast. This is my explanation. And but what is sure is that patient refer to have to still have the feeling on the nipple areola complex. And when you compare two groups, you can see the difference. What is important is also the psychological, I think, the psychological aspect of this operation. If the patient have a very good feeling about their body and have a very good satisfaction of the operation that she go through and so on, can have also the possibility to reestablish a relationship with the breast, you know. It's something that I cannot explain, but it's a feeling that I had in these 6 years. I don't know if the patient have the hope to go a very mini-invasive operation that are happy for that, and maybe they answer better to the questionnaires. This can be, but why you don't have to give this opportunity to a patient? If they feel better, maybe they are not better, but they feel better, so why not when they receive mastectomy? For the innervation, I have this idea, because I cannot prove it by physiological examination. First, to answer to your comment at the beginning, I also have to fight with urologists, especially with gynecologists, and head and neck, and so on, thoracic surgeon who want to use one of the 3 robots we have in the institute. But if you start with this project, you don't need to do so much patient at the beginning. It's better you learn by yourself to do the right technique, take your time in operative room. So maybe you just need 1 day per month, you know, and do 1 patient per month. And I think you can find a place for that. Regarding the costs, of course, this is a very expensive operation. But when you do robotic surgery, you spend the double of a normal mastectomy. This is the calculation in Italy. Every country have its prices of the instruments, of the robotic operative time, and so on. But in Italy, this operation cost the double of the normal operation. But when you start to study this project, and when you talk with the patient that you have a robotic mastectomy, many patients write on the social, they invite you to the TV. So you do 1 robotic operation, and you gain something like 10 patients to your center, and they come and they are not looking for robotics. They are just looking for a very good breast oncologist. So I think you enlarge your volume in your breast unit, and you can do, cover the cost for that only operation that you do per month with this method. If you work in a referral center, I think you have also to offer this operation. This is my opinion.
Very good. I think the hardest part, who has ever watched the robotic surgeries you've done, I think the curves, the timing of learning curves, at the beginning, you don't know how to put the patient, how to dock the robot. It's a very, very difficult step. And you guys were the pioneer, like you saved 4 or 5 hours, I think, at the beginning to discover which was the better position, where to put the arms, and where to dock the robot. So that's really, you opened the way for us. About the reconstruction, I would just like to say some words. Of course, you are much more experienced, and what we've seen at the beginning, I think Manconi, with you started doing subpectoral reconstruction. But I think it was very difficult because of the bleeding, and there are some issues with that. And most of surgeons now, they perform the pre-pack reconstruction, either with the mesh, the ADM, which increases a lot the cost for the surgery, and we know the cost is a problem everywhere, but mainly here in Brazil. Or, for example, in France, in Paris, Sarfat put the implants pre-pack, and he already schedules another session of lipofilling for the patient, because most of the patients are thin patients with a pinch, a very small pinch, and they will develop some rippling. So at the end, most of them will need a lipofilling to get a better result from the breast. How do you feel about that? And what are you doing in the institute?
So we started in 2014. We started with retropectoral reconstruction. It is very easy. It is very easy because the axillary access give you a very good visualization of the retropectoral area. When you go inside with the camera, you can see the pocket in front of you, the muscle. So it's very easy with the instruments to dissect the major pectoral muscle, and it is fast, and I have to say safety. And we started with this reconstruction because we didn't have in 2014 we didn't have experience of prepectoral reconstruction. So we started with this dissection because we were accustomed to do that for open surgery. And also for the randomized trial, all the results compared to groups of retropectoral. I didn't want to introduce a new variable during the randomized trial, because if you have to compare two groups, the two groups itself, each group must be homogeneous. So I started to use the prepectoral for the robotic mastectomy at the end of randomized trial, and it was a real success, really. And at the beginning, I started with the cover of a mesh with ADM. We use a very normal ADM, and we cover the implant. But I also know the technique of Benjamin Sarfati, which is a real friend, and he used the prepectoral without the mesh. He used the Polytech in polyurethane implant. And of course, without the mesh, you have to do the lipofilling, the fat grafting after some months. But this is the same problem that you have when you do reconstruction in open. It's exactly the same. So the fact is that we have to invent a new kind of reconstruction. And if we don't find the right way to make a reconstruction, you will have the same problem in robotics, I think. And but I think there is no difference between the reconstruction of open or robotics. Of course, the prepectoral reconstruction is more easy to do that. You just have to choose the right implant for the right patient, and close the wound. So it's more easy, and more at the end the results is much better, because you have a lot of doses. You know, if you do a monolateral operation, you don't have to touch the other one if you have a very good breast on the other side, so you can save and you can spare some time of operation. So I think it's much better. I don't have a long-term results of this prepectoral in robotics, but I don't have postoperative complication for that, so I will wait for long-term results.
Perfect.
So can you say that you have abandoned the muscle to put the implant behind the muscle? You're only doing prepectoral now?
Well, I only do in robotics prepectoral. Yes, after the randomized trial, I decided to do a series of prepectoral reconstruction, robotic associated to prepectoral reconstruction. Yes. Now I only choose patients that have the opportunity to make a prepectoral reconstruction. Yes.
So this comes us to one question about the limitations. I mean, what are the limitations? What kind of patients we need to select to do robotics? Because it's not for any patient that has an indication of mastectomy, correct?
Correct. This could be a very big mistake. I think you have to select the patient. This kind of technique is not for everyone. If you want to apply robotics to all the patients that need nipple sparing mastectomy, it's a mistake. I think you have to choose patient with high expectance about cosmetic outcome. this is important because there are some patients that doesn't have this need in their mind. So first, you have to have a very motivated patient first. Second, the patient doesn't have to have some high risk factor, such as smoking, such as diabetes, such as obesity, such as all these kind of risk factors, especially if you want to start, because if you start with a complication, it will be difficult to justify this technique in your hospital at the beginning. So choose the perfect patient when you start, and the perfect patient when you are not so good as a robotic surgeon. It's better to choose a very small breast patient, so you will employ less time to do operation. You will have more fat, so you will have less serum after the operation, and the rate of infection in a very slim patient is lower. So it's better that you choose this kind of patient. Regarding in general, the patient that can receive this kind of operation, all the cap A, B, and C breast size and all the ptotic with grade 1 or 2. But today with the prepectoral reconstruction, I also can say also grade 3 of those, it can be enrolled in this technique. Of course, if you have a patient of 65 years old, you don't spend the double amount of money to do this kind of operation. You have to choose a very young patient, that have a very, which is motivated, I think, and this must be your patient, I think.
Perfect. You just answered Darley's question, Toesca. That was this one. You can put here, Ari, please. He's asking about if you patients with moderate or large ptosis, as you told, is worth doing this type of surgery. So if you're a beginner, the answer is no. And if you're an expert in this kind of surgery, maybe you can try, right?
Yes, correct. Let me say that when you have a larger breast, a very large breast, you have too much skin, So you need to reduce the skin. And if you do a robotic surgery with an incision outside of the breast, it's difficult. Well, should I answer?
Sorry.
I think so. Yeah.
I just come back. I fall here.
So we receive a question from audience.
Yes, that's one. That's the one that you just answered. I have another question here. I have a question from Daniele. It's a very interesting question. I'm gonna put it here. What about your axillary approach, Toesca? If you have to do a sentinel lymph node biopsy or axillary dissection, you do it by the same incision. What about your technique for this kind of procedure?
So when we start the operation, we do the 2.5 centimeter incision in the axilla, and with open surgery, we do the sentinel node biopsy from that incision, which is placed in the axilla. So it's very easy to find the sentinel node biopsy. In case of axillary dissection, that can happen during the operation. In case of axillary dissection, we complete the operation, we end the operation, and then at the end, in open, we enlarge a little bit the incision in the axilla, and we do it open. We didn't want to invest time and money to study the robotic axillary dissection, because maybe in the future, we won't use the axillary dissection anymore for early cases that undergo to mastectomy. So I don't want to invest this time to research something that is going, away.
Toesca, can I ask you a question?
course.
regarding that, when you will find like a sentinel node positive, we see many papers as in your trial that the patients select to the surgery would be those patients that will not go to radiotherapy. Mainly, I think because of the prepectoral reconstruction and the higher rate of complication. How are you dealing when this patient needs radiotherapy? And have you seen any of them in medium follow-up, medium time of follow-up? And how was the outcome?
Yes, this is a very good question. And I think this is the only question I don't have an answer. Because in the majority of patients that need radiation therapy were very few. I remember 5 patients that need radiation therapy were with retropectoral reconstruction. So the implant was protected, was behind the muscle, and so they have a capsular contracture with the rate of usual retropectoral reconstruction. I don't have an answer for robotics more prepectoral because I didn't have cases of radiation therapy. The bibliography, the literature, says that the prepectoral also go better than retropectoral, but during the radiation therapy. But I don't have a direct experience yet.
Okay, perfect.
Yeah.
Elio, do you have any other questions from
I have a question from Regis here, our friend Regis. Ari, please can you put the question here? Congratulations, Toesca. Do you think I think that you have already answered that, but let's explain again. Do you think IDM is really necessary to this surgery? With prepectoral reconstruction is repeated more often, and how do you manage that?
Thank you very much, Regis. Yes. Thank you very much, Regis. This is a very good question. No, I don't think ADM is really necessary for this kind of surgery. We are trying to do this operation with prepectoral reconstruction with the use of polyurethane implant to avoid the ADM. And we are doing it. We are starting now to study, so we will have some results in few years. And of course, if the mastectomy flap is well vascularized, is well done, we shouldn't have problems with prepectoral without ADM. This is my concept, but we have to test and we have to see results in few years in some cases.
One of the main things that we look in breast during the mastectomy to prepare for the reconstruction is to dissect and to see the perforators coming from the inner upper inner quadrant of the breast. What about how about on robotics? I would expect that it's even better to see and to preserve those vessels. Is that correct?
That's correct. And it's very easy to find it. It's very easy to recognize it. It's very easy to save it. Sometimes not. And when you when you dissect it, you are in trouble in robotics. And it happens a couple of times that because maybe you can't see it, maybe because you are dissecting. It happens a couple of times. I couldn't see in time, and I dissected, and it's very difficult because you start to have a lot of blood inside, and you must be very ready to take the vessels and then to organize yourself. Sometimes you have to work with one eye. In robotics, you have 3D vision. So you have two eyes, left and right, that give you the deepness. Sometimes maybe the camera is dirty. You have to close one eye, or you have to try, like in laparoscopic surgery. It never happens that I had to convert the patient, but can happen. and I think it will happen. I think I hope later and later, but it will happen. Yes.
Perfect. I have another question from the audience here, Toesca. Dr. Linhares. I think that he made the first robotic mastectomy in Brazil, and he's asking about your experience about robotic mastectomy after new adjuvant chemo. Do you have something to tell about it?
Well, we had these cases also during the randomized trial, and we choose for this kind of enrollment patient with a good clinical response after the chemo. Of course, the patient, you must be sure that the patient in the initial stage didn't have a superficial cancer with involvement of the skin. Of course, you have to choose a patient for this operation that doesn't have involvement of the skin. Of course, you cannot choose a patient with nipple complex involvement. So if the staging of the patient before the chemo was for example, a multicentric breast cancer without the involvement of the nipple complex and the skin, you can enroll the patient to the robotic mastectomy without a problem, I think, as in open surgery.
All right, perfect. Thank you. João, do you have any comment?
Yeah, talking about you're talking about the Polytech implants that you're trying to experiment with them now. Why do you think they avoid the meshes? Because they get more stick to the tissues, and they have less contraction,
rotation,
and less rotation also.
Yes, well, I think so. My data comes from Paris, from the friend Benjamin Sarfati, who started to use the Polytech some years ago in open surgery and apply it to the robotic surgery. And with the Polytech as it is like a texturization, but it's not, because the material is in this way. It's not done in the lab. And it seems that it stay in the place where you leave it. In fact, when you use it, when you play the put the Polytech, you put it in a position, and it will stay there, doesn't squeeze inside. And the fact is that also the skin can can stay on the implant very, and this is the fact. In fact, after some months you need to do fat grafting on this patient, I think. But you save a lot of money because the Polytech are less expensive than a normal implant, and you don't need the ADM. So we are trying this. This new procedure, this new implant.
They are very good. The problem is when we have to replace them, because they adhere to the tissues. It's very hard to take out when you need to replace it.
Yes, it is. Yes.
Actually, João, when the polyurethane, in fact, what happens, because it creates it's textured, and it puts the implant, it's fixed almost in the subcutaneous flap, and it creates a capsula outside the implant. So you should have a thicker capsula without contraction. That would be the reason to use it. But in the other hand, I see that one also asked here, we are living in the days of the breast, the capsular lymphomas, and polyurethane was one of the blamed one for the anaplastic large cell lymphomas. Even now in Paris, they banned all the implants. Now Benjamin is using the smooth one, and he's terrified by that because it will make a lot of rippling and a lot of capsular contracture. So now it's I don't know how it is in Italy, but we are facing some problems with the very textured implants like the polyurethane. And do you have any data about that? And it's okay to use? How are you using that in Italy, Toesca?
That's a question that
Fabrizio, let me say that we don't have important data on this. We are in a very, how can I say, in a very bad situation because when they remove all the textured implants and so on, we started to use in Italy, but in all the part of the world, different kind of implants and so on. But we don't know the effect in some years. Let me say there are no data on this. And I have a personal opinion, but it's just a personal opinion. I have to say that all the implants of all the implants in the body can create a lymphoma. I think so. If you use a kind of implant and so on, any kind of implant can create this lymphoma. This is my personal opinion. We will see it in some years. It's not because of textured or not. This is my opinion.
I have a practical question here for Fabrizio. Fabrizio, you told us that you start your certifying process of robotic surgery in Brazil. If you can explain for the audience, which are the steps you have to do to make this kind of surgery here in Brazil?
Well, we talked a little bit before with Toesca. There is no, for example, even though we have many published articles as the trial from Toesca, the breast surgery is still considered like a experimental surgery. So there is no specific training for breast surgery using the Da Vinci technology. You know, the Da Vinci technology will be when the have a patent, the license, the patent, it falls. There will be many other robots for surgery. But nowadays, for Da Vinci, breast surgery is considered experimental surgery. So to perform it, you have to have one license on gynecology, for example, what I did, or in general surgery. Then, when you are going to practice in breast, you have to have the approval on your committee, hospital committee, or the in charge of the robotic surgery to say, okay, go on and do in breast, but you are not secured by the intuitive, for example, the Da Vinci company. The hospital take all the blame if anything happens. So the training starts with some theoretical classes. Then you have to do the simulator hours. In most of the hospital, São Paulo hospital, you have some simulators that you can practice on that. And then you go with a scheduled time in, for example, the EarCAD with the intuitive company. You go with them and you operate, you do some exercises, and then you operate an animal, for example, pig, and then you'll be certified or not to start doing surgery in gynecology or general surgery. And then you have to work on your working place to be able to perform it in breast surgery. Toesca, do you want to say anything?
Yes, I totally agree. Also in Europe, it's the same. This procedure is considered experimental. So when I do courses, every time in my institute, I open the courses doing a presentation how to start with robotic mastectomy. And the first step is to open a trial. It's very easy. Just go to the internal review board, ask for the authorization to do a trial, a prospective consecutive patient trial. Very easy to observe postoperative complication, the feasibility and safety. That is enough to have the insurance for the patient and to cover the patient if you have some problems. That's it. Let me say that Intuitive Surgical don't have responsibility also for the usual robotic surgery. The responsibility is on the hands of surgeon always. So it is true that Intuitive Surgical say we don't have responsibility for experimental surgery, for breast robotic surgery. They say they have responsibility for other surgeries, but it's not. They only have responsibility if the robot have some problems, which is different. But the responsibility it's always of the surgeon, I think. So nothing changed at the end. If you ask to your internal review board, they will give you the okay to work. Just collect the data every time you do a surgery, and then publish at the end. So let's start.
Perfect. Well, it's more than 1 a.m. in Italy. I think that Toesca is very tired. I have just one practical question. The last question here from Renata. What about suction drain, Toesca? How do you place that in the robotic surgery? And that's the last one.
Okay, we usually use a suction drain. When we do retropectoral reconstruction, we use 2 drains. One in the mastectomy flap, and the other one on the retropectoral pocket. When we do prepectoral reconstruction, we just use 1 drain and we put it on the inframammary fold.
Perfect. So that's it, Brunelli, Toesca. We are very thank you for your beautiful presentation, your talk with us. We learn a lot with you. Thank you for being with us. Thank you for all the audience that were with us for more than 1 hour here. And that's it. João, you have something to tell?
Well, no, just to thank Toesca and Brunelli for the kindness of sharing with us their knowledge and experience. Thank you for your patience, Toesca, to stay so late at night. And if you just want to make your final comments, we appreciate it very much, your participation, both of you.
Well, just let me say it was a pleasure to stay with friends. Put your mask and come in Milan.
Yeah.
No, Toesca,
can't wait for that.
You have a course, right? Once a year of robotic surgery in Milan, right?
Well, I do it every 3 months. I had a course for a Brazilian in the end of February. Just some days later, the lockdown in Italy.
Yeah.
So we had to close the course some days before. And it was a very bad situation, but I will start again when we will be free from this coronavirus disease.
Yeah, for sure. Well,
for sure.
Stay safe. Thank you very much.
Thank you.
Take care and hope to see you soon. Thank you, everybody.
Thank you, friends. Thank you, everybody. Thank you.
Grazie,
Bye-bye.
Antonio. Ciao a todos. Obrigado.
Ciao. Bye-bye.
Bye-bye.